I'm Donna Coots, and I wanted to be a nurse since I was 5, and have been a nurse for about 35 years. Did a lot of cardiology initially, spent 7 years in Kenya, worked with kids there, and when I came back, someone directed me to the hospice idea because they thought I would be a fit for me. So that's been about 8 years, and it is a fit for me. I absolutely love it. People hear the word hospice, and most often people just say, nope, 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 you know, not going there, because that means one of two things. Either their patient is dying, which of course they are, but I mean, that means they're gonna die, like, that means you're saying that they're dying tomorrow, or the next, or really, really soon.
Right.
Or that means we're giving up. Those are the two things you hear all the time. And hospice is about coming alongside to make the remainder of the patient's life as comfortable and as quality as possible. We're not going to change the date of when they die. Just because someone comes on hospice doesn't mean that they're going to die sooner or later than they would have. That won't change. But we can make that journey so much easier. Taking the burden off the family for that constant decision making. We can help them make some decisions about care. We can provide our home health aides that are bathing so that the family can be more family than caregiver. Pain control is always really huge. We come alongside to give the right blend of medications so the patient is comfortable. And I always say to them, what's our goal here? What's our goal? Our goal is comfort and as much quality of life as possible until they pass. After I'd been in hospice about 4 or 5 years, my dad ended up in hospice about an hour away. So I wasn't always totally involved with his experience, but did get to know his nurse and was there for some of his care because I helped with that. And by the end of my experience with his hospice experience, I thought, wow, like hospice is wonderful, because I was seeing it from the other viewpoint, not as the caregiver or as the official nurse, but more as I was the family.
Yeah.
And I was really impressed with how wonderful they were. There's probably several components to that. One of them is just who I am. I am a very compassionate person. I am a merciful person. I'm a highly people person. Like, don't put me in front of the computer. I hate it. I don't like paperwork. I am a people person, and I love loving on people, leaning into them, hearing their heart, knowing what's going on with them. I find with hospice, obviously, it's just as much about the family as the patient, because it's the whole ball game here. Mm-hmm. And so whereas my focus is the care of the patient, the family and how they're doing and how they see my role and how they see hospice and how we work together is really, really important. And so I'm very honed in on the whole picture of the family and really get to know all of them well. I always want to make sure that they are feeling comfortable with what we're doing and answer all their questions and, again, be a really, really good listener. Another part of it for me is I'm comfortable with my mortality. I'm not afraid of death because of my relationship with God, and I know that I'm going to be in heaven someday. And so when I'm with other people that are going through that journey, if they have a strong faith, we have that in common, and they like me to pray with them, and I can hold the patient's hand and talk about what's going to happen next based on what I believe is true. And then for people who are fearful because they don't know what's next, because they don't have a faith, because that's all uncertain for them, it gives me an opportunity to come alongside them and say, you don't have to be afraid. You don't have to be afraid. There is hope for beyond death. And so then I have some opportunities there as well. We get referrals. A lot of times the referrals are from a doctor that have determined that their patient is ready for hospice. Or it might be a friend or another family member of that family just says, you know what, we had a family member in hospice and it's really helpful, I think you should make that call. So our office will get that call. And so our intake nurse takes a little bit of information on what's going on, what their diagnosis is, and then we need to get documentation from a doctor that states why they feel that this patient has a prognosis of approximately 6 months or less. So we have to have some documentation and a diagnosis that fits. And so we start with that, and if all that is in place, then we agree to the admission. Then one of the nurses goes out for an admission visit. And I should back up and say sometimes we do a referral visit or an informational visit where someone's trying to consider, is this a fit or not, and we'll just go out and tell them who we are. And so we might do that first if that's needed. But otherwise, if they fit criteria and the family's made that decision and the patient has when they're able, the nurse goes out for an admission. And so during that time, it's a little bit involved. We try to just tell them again, if they haven't already heard, who we are and what to expect from us. And we have to do some initial paperwork. We've kept that as basic as we can, but there are papers to be signed that they agree to us coming in, that they're not going to seek curative measures because that doesn't fit with the hospice philosophy. So once they understand all that, we sign the papers, and then we do a head-to-toe assessment of the patient. So we know exactly where they're at, what's going on, so we know where to start with their care, get a list of their medications. Then very quickly we touch base with our hospice doctor because most of them go under the care of our hospice doctor. If they have their own doctor that they want to continue with, that's okay, then we work together with them. But most doctors want to give it to the hospice doctor. So we immediately connect with her, go over the medication list, kind of talk about the plan of care. When we're with the family too, we just say, okay, this is what we're seeing initially, that probably we'll start off with, well, we do 3 days in a row of visits just so that we make sure that we're in a good place, and then we decide, are we going to come twice a week or once a week or 3 times a week based on how the patient's doing then, which can always be tweaked. Do they want home health aides in? Do they need other equipment, which we can readily take care of very quickly. And constantly say, if you have questions, here's the one number that you call now. You don't have to call 5 different doctors. You don't have to go into the emergency room. You don't have to do all those things. Here's the number you call, and we're available 24/7 for any of your questions or concerns or needs. The care team would include the nurse who is the care manager for that patient, and then along with the nurse is going to be home health aides to come and give personal care if the patient is ready for that. It might be down the line. Our social worker is an important piece. He's going to come in, he or she is going to come in and talk about if there are financial needs, because sometimes there are real concerns, and that social worker can come in and just help them in that process. Also, he can help with just safety issues in the home. He can help with maybe family dynamic issues that might be going on that he's got an expertise in, and a lot of times the nurse and the social worker work together on that because the social worker isn't usually there as frequently as the nurse, although he or she can come in as often as needed. We happen to have an amazing social worker who's very, very involved and quickly senses the dynamics in the home and picks up on things that we may not, and helps us do more holistic care. Also, our chaplain is an important part of the team, and our particular chaplain is so amazing because whatever the faith walk of this particular patient, whether it's a God focus or another faith or no faith in anything, he comes in and meets them where they are. It's a beautiful thing. He really gets to know them, helps to journey with them wherever they are, and is a real important piece of our team. So those would be the main pieces. Boy, that's a hard one. I would say I've probably been at the bedside with 20 to 30 maybe. It's hard to say because oftentimes when I'm called in, it's after they've died.
Right.
And so I come in to do the pronouncing and arrange the connection with the funeral home. But actually being there for the death, I don't know, maybe it's not more than 20, but it's around there.
Any positive, negative interactions that you've had that stick out in your mind with a funeral home?
I mean, pretty much it's just getting information. I have had some experiences where you feel like the person on the other end of the phone is just doing their job. And, you know, when I might say something about the needs of the family, it's, yeah, just one more thing for them to deal with. Now that's unusual, I would say.
Yeah.
But for the most part, you know, taking care of that information over the phone has gone fine. And so I don't really see what happens with the family when they're dealing with the funeral home because that's usually the next day.
Right.
Yeah.
How often do you connect with a family so much that you end up going to visitation or going to the funeral for that person? Or do you kind of draw a line for yourself that you're not going to get immersed to quite that level?
It's common for the nurses in the hospice that I work for to go to the funerals or visitation of patients that they have a relationship with.
Okay.
And that varies a lot. You know, sometimes we have patients for months, and sometimes we have them for hours before they pass away. And I would say a lot of it depends on what happens in that dynamic with the family. Mm-hmm. I have had times when I've only known the family for a brief amount of time, but there was such a connect there that I have gone to the visitation.
Yeah.
It doesn't always work out schedule-wise, but yeah, it just seems like the nurses that I work with and myself, we have this inner knowing that yes, this would be really significant to the family mm-hmm. if we were there, and if that's the case, we go.
Well, I think it shows that extra to the family that you weren't just there doing your job, you cared for them.
Yes.
And you cared for that person. You weren't just taking care of them, which is, I think, a very important thing to do when you're in that kind of position.
In 40s to a current one that's 101. We have one that's probably going to be joining us soon that is a teenager. So we don't as commonly deal with that age group because obviously there aren't as many people needing hospice in that age group, but certainly our hospice would take anyone that fits the parameters. But for me, yeah, I haven't had anyone younger than 40 and currently, like I said, 101.
No, I know that there's such a thing as a pediatric hospice nurse. So do certain hospices have somebody on staff that's trained for pediatrics? Or like, how does that work?
I can't really speak from very much experience there. We do not have a pediatric person. Our hospice is smaller, and I have heard that there are. So I would think that would be a really helpful piece for those with children, just because that's their area of expertise then. But I personally don't have experience with that. Well, usually the situation is when we hear that, well, I don't know that I've heard that since I've started working where I am currently, but usually what the situation is that they've waited so long to bring their family member into hospice. You know, now they're desperate. And so they bring the family member in. We need to control symptoms, whether it be breathing or pain or whatever it is. So yes, we introduce morphine because that is I'll just say, it's one of our best friends because it is amazing how it is helpful for pain and for breathing, making the patient way more comfortable in their last hours, days, weeks, so much better than they would have been. But if that patient has been brought in when they're very, very near death, but we still need to do some symptom management and we give morphine, and the next day they die, then the family is saying the morphine killed them.
Yeah.
The morphine did not kill them because we don't give anywhere near enough that could possibly kill them. In fact, recently our doctor said the only way that it could have that kind of effect is to have 3 bottles of morphine chugged all at once.
Wow.
Okay, well, the bottom line is that's never going to happen. It's very, very, very safe. So when they're saying that the morphine killed their mother or whatever, it didn't.
Yeah.
But it was the timing, and they're struggling with the death and all of those things. There's nothing that we do that hurries it along or slows it down. I would say that's fairly rare, but it does happen. Generally, when we take someone into hospice, their prognosis, as best as can be determined, is approximately 6 months or less. Now, again, we don't know that. And their diagnosis has to fit what is acceptable for hospice. So if they start to improve or stabilize for a long period of time, and they're recertified every 3 months.
Okay.
So every 3 months we reevaluate. And if a decline is taking place at all, we're going to keep them. But it has to be documented. We're put under the rules and regulations of insurance, and also just other rules that are set for our parameters. So there is the occasional time when a patient just stabilizes and they just stay stable and they're not declining. And we try really hard to be able to document some decline because we're not trying to get rid of anybody. And they love our care. But if they stabilize too much for too long, several recertification periods, we never just do it after one, then we have to start introducing that thought. And if we do, we introduce it way ahead. And we're talking with the family, and we're making sure that they understand the rhymes and the reasons for it. We are definitely then connect them again with their primary care physician. We make sure that they're going to get ongoing good care. They also can come back with us at any moment. We can bring them back in. So we try to stay connected a little bit and make sure that they're not, they don't feel dumped. So I would say it's more unusual, and we have people, many times we have people way over 6 months.
Yeah.
They're still declining, but they just haven't passed yet.
Yeah.
Absolutely. Yeah, it's kind of a flow over from my day-to-day life, my work and my life, and what I do with other relationships. I do a lot of one-on-one with women, and come alongside people in general. And so it all flows together. I really feel that. I don't really separate it all out. Who I am just is across the board in my day-to-day, in my connection with my local church, and how God uses me there flows over into how I feel like God uses me in my workplace, because it's all a heart. It's a heart issue, it's a compassion issue, and it's who I am.